Good afternoon, and thank you for joining us today. I'm Elizabeth Kennedy Gish with the Seminars and Symposia program at the Smithsonian's National Museum of the American Indian. I'm honored to welcome you to today's program, a partnership of the National Museum of the American Indian and the Indian Health Service. COVID-19 in Indian country focuses on a pandemic that has caused widespread suffering and has disproportionately impacted Native communities throughout the United States. The program features distinguished experts in conversation about combating this devastating pandemic in Indian country. It is now my pleasure to introduce our program moderator, Dr. Charles Grimm. Dr. Grimm, an enrolled member of the Cherokee Nation, is the Chickasaw Nation's Secretary of Health. Dr. Grimm previously served in various leadership roles for the Cherokee Nation Health System, ultimately serving as their executive director. Prior to that, he received unanimous Senate confirmation as the director of the Indian Health Service, where he administered the nationwide multi-billion-dollar healthcare delivery program from 2002 to 2007. And now I give you Charles Grimm.
Thank you, Elizabeth, for that introduction. Welcome, and thank you for joining us today on an important conversation about the COVID-19 pandemic. I'm honored to moderate this panel with these leaders in the pandemic response who've diligently served our American Indian and Alaska Native communities throughout this pandemic. This program is a partnership between Smithsonian's National Museum of the American Indian and the Indian Health Service. And thank you to the NMAI for providing the technical support and expertise to bring this important topic to the communities that we all serve. As many of you know, American Indian and Alaska Native people have long experienced lower health status when compared with other Americans. However, the COVID-19 pandemic has increased the focus on some of these health disparities and challenges. According to a recent report from the CDC, the overall occurrence of lab-confirmed COVID-19 among American Indians and Alaska Natives was 3.5 times that among non-Hispanic white persons, and the highest hospitalization rate of any racial or ethnic group. In addition, the cultural impact due to the loss of elders, native language speakers, and traditional knowledge has been devastating to many tribes across the nation. Our conversations today will focus on the unique concerns of American Indian and Alaska Native communities as we hear from our panel of experts about battling this devastating pandemic in Indian country. The IHS continues to work closely with tribal partners and state and local public health officials to coordinate a comprehensive public health response. First, we'll hear from Rear Admiral Michael Todt, Chief Medical Officer of the Indian Health Service, on the agency's function and strategy to respond to the coronavirus pandemic. Next, we'll hear from Dr. Loretta Christensen, Chief Medical Officer of the Navajo Area Indian Health Service, on the response and challenges the Navajo area has faced. And finally, we'll hear from Phyllis Davis, Tribal Council member of the Gun Lake Band Potawatomi and Chair of the Great Lakes Area Tribal Health Board. After we've heard from each speaker, we'll have a brief panel discussion followed by a few questions from the audience. And with that, I will hand it over to Dr. Todt, IHS Chief Medical Officer, for our first presentation.
Thank you so much, Dr. Grimm. I am Dr. Michael Todt, as introduced. I'm the Chief Medical Officer for IHS. IHS is an agency within the Department of Health and Human Services, and we serve as the principal federal agency responsible for providing a comprehensive health delivery system for American Indians and Alaska Natives. Our mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. We serve members of 574 federally recognized tribes or nations in 37 states. We have more than 15,000 employees nationwide, including healthcare providers like doctors, dentists, nurses, pharmacists, dietitians, and optometrists. And we also provide a comprehensive environmental health program that includes environmental health, injury prevention, and safe drinking water and solid waste sanitation facilities construction throughout Indian country. During this pandemic, we have definitely seen the impacts of American Indians and Alaska Natives having higher rates of underlying chronic disease. We also know that American Indians and Alaska Natives are affected disproportionately by social determinants of health. COVID-19 has definitely disproportionately affected our indigenous communities. American Indians are more likely to get COVID-19 infection, more likely to be hospitalized, and have higher mortality rates due to COVID-19. In fact, a recent MMWR published in December showed that mortality rates among American Indian Alaska Native persons were higher than those among white persons in all age groups except the oldest age group. The largest differences were among persons in 3 age groups encompassing 20 to 49 years. In the 20 to 29 years, 30 to 39 years, and 40 to 49 years respectively, the COVID mortality rates were 10.5, 11.6, and 8 times those among white persons. So really quite disproportionate and at younger ages. Our strategy, as you see from the diagram on the right, is to prevent, detect, treat, and recover. And we have the underlying priorities as well to manage resources and provide situational awareness. Next slide, please. The IHS has a function in providing that situational awareness, and I'll briefly go over the epidemiology as we've seen it throughout those IHS tribes and urban Indian organizations that are reporting data to the IHS. To date, we've tested 1.9 million, as you see the number there in the lower corner under total tested. Almost up to 2 million tested, and of those, 182,000 have been positive. Our cumulative percent positive has been running at the 9.9%, but our 7-day rolling average positivity, fortunately, has been falling, and that's the number that really tells us what's going on with the most recent tests and shows more responsively what's happening with epidemiology. That number was much higher, especially back in the winter and fall. And in all of our areas now, we're below 15%, some areas below that 5% mark as well. Next slide, please. We definitely, in addition to the great geographic variation that was highlighted on the previous slide, we've also seen a definite change in the trends of the positive cases. Early on, the IHS was very quick to work closely with our tribal partners and state and local public health officials to coordinate the comprehensive public health response, starting our incident command system here at headquarters. And then we saw the rise over a rather slow relative to the fall, a slow rise in the rates, first starting in the Pacific Northwest and then affecting very rapidly the Navajo area. And where we saw the rise in the summer, we did see then a decline in cases towards the end of the summer. Unfortunately, we saw a rise again in the daily number of positives from September all the way up until the end of the year. And we did see peaks around the holidays, and that follows the epidemiology. We understand that that COVID-19 tends to spread quick among those who are in close family settings. And so those gatherings of community members tended to fuel some spread as well. The dark line is the cumulative number positive. That line won't come down. It always either goes up or becomes flat. And again, the encouraging point here is that it's beginning to flatten, as we talked early on about flattening that curve. And that's a good sign. Next, please. I'm going to go through our strategies in terms of the IHS response. In terms of prevention, the 3 W's have to be communicated well amongst our staff and our community and the tribe, and that's wearing a mask, waiting 6 feet apart or remaining socially distanced, and washing your hands. And those 3 Ws remain an important part of the response, not just in staff prevention, but also in community control. So it's important that we message this in different ways to different populations, but it's the same message, and we want to prevent spread, even with the efficient distribution and administration of vaccines. We need to continue to practice those 3 Ws. We do need to continue to work on increasing vaccine acceptance. Some people call it, on the other side of the coin, vaccine hesitancy. I prefer the positive term of vaccine acceptance. But the point is that we need to engender trust among our community members. And we found some best practices from tribes and tribal leaders in having native speakers or tribal elders or native healthcare providers, or preferably all of them, delivering those messages to their own community. And that really has helped with increasing vaccine acceptance. Of course, there are CDC and national campaigns that we participate in as well. But that local trusted elder and senior community members is really what seems to be helping the most. We all have to continue to be very careful about using our PPE. I say avoid COVID fatigue. I don't mean the physiological fatigue from getting the virus. I mean the fatigue from having to wear a mask, having to do these 3 Ws. It's challenging for healthcare providers, challenging for community members, and we have to maintain our will. Next slide, please. In terms of detection, this includes screening and testing. Screening is what we do in terms of asking someone if they've been exposed to someone who's had COVID-19, or checking perhaps their temperature. And that's important in different settings to be applied in different ways. But testing also has now a more prominent role, and that includes diagnostic testing, where we're trying to find out if someone has been infected and has the virus that's detectable. Contact tracing, where we're looking for an individual who is asymptomatic but has come into contact with someone who's positive. And then surveillance, and that's the activity where we're checking to see whether or not an individual might be positive among certain groups. Some suggested groups that we do surveillance testing would certainly be in the highest risk, doing surveillance in our elders, in those with chronic disease at any age, those who work in commercial food production, such as canneries or meat packing. Our strategy has been to get the national goal to exceed the per capita testing rate for the US. We have done that and maintained that. So the 2 million tests that have been done in Indian country, that's at IHS tribal and urban Indian organizations. It's through a partnership of all of us testing. We've been able to test at a higher rate than the nation. But we also want to get our positivity down below 5%. And as I reported it at 7.7, we're not quite there yet. We did previously have an interim goal of getting it below 10%, and we met that. So we've upped our goal, matching it with the World Health Organization's goal, and are now targeting to get that below 5%, and then to drive it even lower after that. We have been able to distribute the Abbott ID Now and Binax Now through partnerships with HHS and the White House to receive distributions of testing, point-of-care testing systems and supplies, as well as Cepheid analyzers through contract purchases as well. Next slide, please. Our strategy in terms of treatment includes making sure that we have sufficient staff, that we're prepared for surges and managing those surges, but we all have to deliver culturally competent, relationship-based care. So even if we're bringing in staff from outside of our communities that aren't used to working with our communities, we have to do on-the-spot cultural orientation, and to make sure that they're not just treating numbers or disease, but they're treating persons in a whole person approach, respectful of the culture. Our therapeutics, we've been fortunate, again, to have strong support in distribution of remdesivir, which is an antiviral, dexamethasone, which is glucocorticoid, as well as monoclonal antibodies such as the bamlanivimab and the Regeneron combination product. Through the distribution of the therapeutics, IHS has been able to treat our patients, as well as our tribal partners have had access to these medications as well. We do distribute them through the National Supply Service Center and have not had any shortages, and we've been able to meet demand for these products. And we have to maintain our readiness. And when we don't have sufficient staffing, we have to have a contingency plan. So one of the things we've put into place at headquarters in our response is developing critical care response teams. These teams are composed of a critical care physician as well as nurses, and sometimes augmented as well with respiratory therapists. And these teams can provide response, so they can provide temporary augmentation of the staffing for a surge situation. They can deploy within 48 hours, but they also provide training, and they have done proactive deployments to sites that anticipate a surge so that their frontline staff can be trained in critical care by providers who have experience in providing critical care to COVID patients. And then we also have to maximize telehealth. Obviously, things have changed with COVID and how we get around, and we want to minimize impact to our patients, but still continue to be able to provide those services. Next slide, please. The fourth strategy is recovery, and certainly in terms of recovery, we need to make sure that we leverage the community resilience, and that's for our staff and for our patients and their families. We have to address trauma. We have to be cognizant that behavioral health issues and substance use issues have been magnified during this pandemic. There's also the issue of unresolved grief in light of COVID-19. Individuals have not been able to grieve in their normal traditions and customs and manners, and that can be really challenging and potentially could have lasting impacts. So we have provided some resources online, as well as we've had deployments of some behavioral health staff in certain cases to help communities and to help our facilities in addressing COVID-19 and emotional well-being. We do have resources available on the ihs.gov/coronavirus. There's some recorded webinars and some other enduring materials. And then also it's important that we monitor and care for those who have had COVID-19. And Dr. Christensen later on in the program will talk more about that. Next slide, please. I want to leave you with my final slide here, and that is hope. With the vaccine distribution, we've now distributed, as of yesterday, 662,850 vaccines. So that's really just fantastic. In terms of administration, we had been running at about 60% of those delivered had been administered until we had a large bolus just shipped this week. So that drops our percentage administered compared to delivered. 306,000 vaccines have already been administered. And actually, I'm giving you data from yesterday, and I heard just yesterday of an event from the Eastern Band, almost 1,000 vaccines in a single day. There have been similar events over the weekend from Navajo, Phoenix Indian Medical Center, many of the tribes in Oklahoma. So there's a lot of vaccine administration, and there's a little bit of data lag as well. So I'm confident that vaccines are being delivered and that there is hope for American Indians and Alaska Natives. So thank you, Dr. Grimm. That concludes my remarks.
Thank you, Admiral Todt, for the overview of what Indian Health Services strategy has been for helping lead and manage the pandemic in these most challenging of times. Up next, for our next presentation, will be Dr. Christensen, the Chief Medical Officer of the Navajo Indian Health Service. Dr. Christensen.
Thank you, Dr. Grimm. I'm so honored to be here today to present the COVID-19 response in Navajo Area Indian Health Service. Next slide, please. Today, I'm going to touch upon our response in terms of preparation, mitigation, prevention, specifically the COVID-19 vaccine and post-COVID-19 care. Next slide. This graphic shows the Navajo Nation, which includes the states of Utah, Arizona, and New Mexico. The Navajo Reservation is 27,000 square miles, and over 240,000 Navajo people have their health care provided by the federal, tribal, and urban healthcare facilities across Navajo. Next slide. So preparation, we began in early February 2020 when we stood up our incident command at the Navajo area office, at which time we did order additional supplies such as PPE, extra oxygen supplies, and even ventilators at that time. Education was provided for the staff with our experts providing ECHO platform teaching across IHS. We did additional education to our providers with particular attention to critical care, as we are very cognizant of our finite number of beds that we have across Navajo. We rely on tertiary centers for our most critical patients, and we realized if a time came when we could not transfer patients, we would have to internally expand our services, including critical care. And I'm very proud to say we did that during both waves of COVID. We had multiple calls with our staff across Navajo concerning current information on COVID-19, and we instituted early quarantines and travel restriction guidelines. We worked very, very closely with the Navajo Nation, and we entered discussions in very early March concerning the need for public health orders. Working with the Navajo Nation president, we were very proactive with shelter in place, mandatory masks, closing non-essential businesses, closing travel across Navajo in our national parks and monuments, and limiting travel of all personnel. For our IHS hospitals, we closed our facilities to visitors very early, shifting to telephonic and telehealth alternatives, as well as establishing early outdoor screening and testing sites, as well as drive-through pharmacy services at all of our facilities. Next slide. Mitigation. We structured our command structure with the Navajo Nation in a unified manner. In the first wave in the spring, and also in the second wave, we had the dubious honor of being the highest number of cases per 100,000 population in the country. We were profoundly affected, and we established our command structure to strengthen our response. Our public health response and medical response branches remained very strong throughout the entire pandemic to this day. In public health response, we were fortunate to have an extremely strong public health epidemiology lead who has been responsible for overseeing data management, data analysis and linkage, testing strategy, public health messaging, case management, community mitigation, gating criteria, and contact tracing. I do want to share that we have one of the best contact tracing programs in the country. Our tracers are culturally integrated, and most of them speak Navajo, which has been a great advantage to us when investigating contacts throughout Navajo area. We have trained over 800 contact tracers and still maintain a workforce of over 400. The medical response team was responsible for the establishment and management of the alternate care sites, isolation and quarantine sites, and we placed over 2,500 people during the pandemic, providing lodging, food, and rapid access to medical care. We also provide subject matter expertise for all the testing strategy, genomic surveillance, explaining the science and efficacy about the vaccines that were developed. And this is presented both to the public and the leadership of Navajo Nation, the Navajo Council, and all interested parties in our processes. During this pandemic, we had to deal with the fact that almost a third of our homes did not have running water. And the mitigation for that, our IHS Environmental Health and Engineering Department, partnering with Navajo Nation and multiple other partners, have been working very diligently to address the need for water access points, storage containers, and distribution of disinfection tablets. Our medical management team also oversees antiviral therapies, monoclonal therapies, and provides the most up-to-date information concerning care for COVID patients to all of our providers across Navajo. Next slide. Prevention. Unified messaging has been one of our greatest strengths, working in tandem with Navajo Nation on messaging. We use radio, which is presented bilingually in English and Navajo. We present live Facebook sessions where we distribute information, keeping all of the public up to date and giving them the opportunity to ask questions. We have an exceptional collection of public posters on all phases of COVID response, including vaccine safety, social distancing, wearing masks, hand hygiene, how to travel safely in cars, limit gatherings, safe traditional ceremonies, and even explaining the COVID-19 variants that have been identified. Our current campaign is community immunity. We are teaching the public how important it is to get vaccinated so we can achieve immunity throughout all of Navajo area. We organized the COVID-19 vaccine plan very early, and we have been in collaboration with all tribal and urban sites throughout. We frequently report, we share dashboards, and we communicate via Zoom or our online calls. We have equitable distribution throughout Navajo Nation. We've developed an online vaccination registry to assist our citizens to getting their vaccinations. And as of this morning, we had administered over 82,000 vaccines across Navajo. We're very grateful for the vaccine that we've received. We feel it's a very tangible weapon against COVID, and we continue to widely administer vaccines across the nation. We do often stress the need for continued public orders. We still have curfews on Navajo Nation, which have just been recently lifted on the weekends to allow us to have our vaccine events on Saturdays and Sundays. Next slide. One of our very deep concerns across Navajo that we feel needs to be addressed is that we have over 29,000 positive cases in the Indian Health Service and over 35,000 cases throughout Navajo Nation. All of these post-COVID patients will need to be seen, evaluated, and managed as soon as possible. In that realm, we have a bi-weekly work group that we get together with all tribal, urban, and federal facilities. We've adopted a functional assessment tool, which is scheduled to be included in the IHS electronic record. And we are using this tool to stratify those who have suffered from COVID, so we know the most urgent patients that we should schedule, evaluate, and manage. We want to determine also what resources we need across Navajo as we gather data on the types of post-COVID sequelae that is being suffered by these people. We want to get the appropriate resources, whether it's via telehealth, bringing more specialists into Navajo, or just providing organized and integrated care plans. We had begun setting up post-COVID clinics at our larger facilities. With the second wave in the fall, we put that on hold, and we are now beginning those programs again. We intend to increase our telehealth with focus on pulmonology, cardiology, neurology, and cognitive rehabilitative services for these post-COVID patients. In closing today, I would like to express my deepest gratitude to all of the staff across Navajo for their dedication, compassion, and the exceptional work that they do every day. And our thanks to the Navajo people for their strength and resilience throughout this pandemic. Thank you.
Those of you that watch national news during this pandemic, and as Dr. Christensen mentioned today, heard of the devastating impact on the local Navajo communities as this disease quickly moved across the Navajo Nation. We appreciate you, Dr. Christensen, today for sharing with us the combined and rapid response of both the Navajo Nation and the Navajo Area Indian Health Service to this terrible pandemic. Up next, we have Ms. Phyllis Davis, Tribal Council Member for the Gun Lake Potawatomi and Chair of the Great Lakes Tribal Health Board. Ms. Davis.
Appreciate that. The Great Lakes Area Tribal Health Board has been in place since 2012 to assist the Great Lakes area tribes and urban centers in improving the health status and quality of life for member tribes and Indian people who reside in this region and in their delivery of culturally appropriate health care. Some of the resources we utilize: National Indian Health Board, the Bemidji Indian Area Health Service, Great Lakes Intertribal Epidemiology Center, the Midwest Alliance of Sovereign Tribes, just to name a few. Next slide, please. Thank you. Representing Michigan, Wisconsin, and Minnesota, we serve 34 federally recognized tribes, 8 urban health centers, and 3 federal service units in northern Minnesota. The tribal affiliation of this region include the Potawatomi, the Ojibwa, Odawa, Oneida, Mohican, Ho-Chunk, Menominee, and the Sioux Dakota, in addition to the many thousands of people who live in the urban areas who have come from all over the country. American Indians from all tribes live in Chicago, Detroit, Milwaukee, Green Bay, and receive their health care there. Tribal size population vary within this region from tribes as small as 200 up to 30,000. And the total patient count from 2016 right now is at 146,920 American Indians who receive healthcare services through an IHS clinic. Currently, there are 20 Title I 638 tribal contracts and 14 Title V or self-governance compacts with the Department of Health and Human Services, our Indian Health Service Agency, which provide funding for healthcare services to American Indians and Alaska Natives in our region. The current level of need funding is 39% within the Bemidji area. This chronic underfunding limits tribes' ability to offer healthcare services that are comparable to the general population. And now with the COVID-19 pandemic, these tribes will have many years of continued funding inequity and additional barriers to overcome while continuing to provide necessary health care. Diseases like cardiovascular disease, cancer, chronic respiratory conditions, mental health and substance abuse issues, kidney or liver diseases rank among the highest in our region. Next slide, please. I wanted to just do a format that kind of gave an impression of what I saw happening through the Great Lakes area. Communications and planning with 34 tribal nations is very unique. And as a sovereign nation, each tribe is responsible for the community that they serve, for the lands that they hold in trust, for the programs that they operate. And, you know, within alignment of the Indian Health Service, so the contracts and compacts that we operate with, you know, the mitigation plan that the Indian Health Service had rolled out was a plan that the tribes did implement within this region as well. Initially, you know, we were informed through presidential declaration and all the federal agency updates started in March, coming from the CDC, the White House, HHS. They were in alignment with the messaging and information out guidance, you know, just general education and informing the public, and the tribes utilize that information as well. In addition to that, tribes have relationships with the states within where they reside with their governors, who are also issuing guidance and orders, and those were in alignment as well with the federal agencies. So this came from many different resources, federal, state, local, health departments. So tribes are required to act accordingly in looking at the welfare of the citizens and the communities in which they live. This rapid infection and transmission swept across the Great Lakes region within a relatively short period. Tribes were determined to protect the health and welfare of their citizens, and in conjunction of the states in which they reside, many of these tribes determined that they needed to close, shut down economic enterprises or government functions and services unless they were determined essential, like public health or public safety services. So this decision for tribes in the Great Lakes area occurred in April, May, and it really was in alignment with a rapid progression and increase of infection rates within the Great Lakes area and how we could protect the health of our people. So essentially, services were shut down that limited healthcare services, dental services, things that necessarily we would try to maintain to stay in communications with our citizens. That happened as well, but it was a very limited process at that time. With ongoing biweekly or local regional meetings, there were opportunities to share this information of what was happening in Michigan versus what was happening in Wisconsin or Minnesota, and to find ways to facilitate our discussions and coordination of services within the area. And that came down through, planning and just communications with distribution of supplies, PPEs, where we saw a shortage in one area. We might have an agency come up and assist with donations or distributions or redistribution, just to keep some of the clinics in the communities operating to do testing. Weekly regional calls provide opportunities to partner with other tribes, the local health departments and states as we move forward towards reducing the infection rate. The tribes have become proactively educating tribal communities on the CDC guidances and recommendations. And this messaging was happening continually throughout the Great Lakes region. And as I mentioned before, this is occurring with 34 sovereign nations in working towards alignment with each other. Next slide, please. Collaborations and partnerships, sharing best practices and model programming became something that we saw happen here quite early on and frequently. Sharing resources to fill in gaps is something that tribes have done for years. And you will always find ways to do what we need to. That's in relation to the historical many years of underfunding that tribes have always found ways to do that, some of the things that they can do. I've heard many positive and hopeful stories related to this ability to work in alignment with each other and assist us in establishing and maintaining positive relationships with our local county health departments, our state government, and our federal partners like FEMA, the National Guard, HHS, CDC, and our area IHS office. This process, along with the communications, helped us in vaccine planning and distribution during the holiday season. Determining the most appropriate plan for vaccine distribution brought us to the table to work out unique situations. We did have discussions and having a short turnaround time for planning, brought tribes to try to figure out what would be the best path if they were going to utilize the state plan and work with the state in distribution and or working with Indian Health Service. And so we came up with some unique situations that had to be worked out. And I think just having the conversations to find ways to serve the people in this region, the tribes have really done a fantastic job in doing that. Next page, please. Supporting tribal sovereignty through consultation. Tribes' unique political status with the United States government has existed since the formation of the United States. As sovereign nations, we are always exercising this inherent right. Opportunities to provide tribal consultation have occurred frequently throughout the pandemic. Many times these recommendations have been heard, but many times not. We will be at the table regardless and do not know that our relationships with the federal government or with our state government are always going to be in the best. We do know this, that they're always going to be in the best interests of the people we serve. At all levels of engagement, from federal agency to state and local levels of government, tribes have been able to voice the needs of the people they protect and serve and hold most dear to them. Culture bearers, language speakers, storytellers, unique young men and women, and beautiful children. We've lost so many treasures in our life that we can't afford to lose anymore, and we will be resilient in our journey. Next slide, please. I provided information that for me as a tribal leader isn't data strong, but impressions of the work I saw and heard occurring on a daily basis for the past 11 months. I'm confident in the work occurring here in the Great Lakes region and across Indian country. Our lives and worlds are connected through this shared space, Mother Earth. No matter where we live or who we are all in this together. Miigwech. And I just wanted to also say that, you know, as of this date, we've looked at 133,000 people being tested, American Indians in the Bemidji area. Our positivity rate, 99,795 positives, 120,000 negative, and our positivity rate is at 4.9%. We're very excited to hear this week that we will be having around 9,000 vaccines distributed to the Bemidji area. We've also heard some encouraging news about vaccine hesitancy and some of the guidance and information and technical support that CDC is able to provide for us. So on behalf of the Great Lakes Area Tribal Health Board, the tribes from the Great Lakes area, I'd like to say miigwech again. And I've really been very honored to participate in this and truly wish the great blessings on everyone and for those people who have been out there since the beginning of the pandemic on the front lines. My heart is truly blessed, and we have much to thank for you being there. Miigwech.
Thank you, Ms. Davis. You brought us a unique viewpoint as a tribal leader within your own tribe, but also as a leader for the Regional Health Board that represents the tribes in Michigan, Minnesota, and Wisconsin. We appreciate you sharing your story today about the efforts of the tribes in that region to plan, communicate, and leverage partnerships to help your people during this pandemic. Up next, we're going to have a panel discussion, and we'll start with one question for each of the speakers to get the panel part of this webinar started. And I'm going to go through them in the same order that they spoke. So the first question will be to Dr. Todt. Dr. Todt, I understand that we're still very much in this pandemic, but can you tell us some of the lessons learned that you'll carry forward when responding to pandemics in Indian country? For instance, how has the healthcare response to COVID-19 changed over time?
Thank you so much, Dr. Grimm, for that question. One lesson that we've learned over time certainly is you can't underemphasize the importance of communication and coordination at every stage between the multiple entities at the local level, at the tribe, the public health authority, which can vary based on the population served, the states, and up to the national level. Really, as the response evolved and we learned more about the virus and moved into different stages, communication and coordination with all these entities was absolutely paramount. At the beginning, we were involved in preventing spread of the virus by concentrating on public health measures, starting our efforts to expand telehealth to help avoid contact while still providing those vital services. With the development of lab testing, we worked to get our IHS tribal and urban facilities the rapid point of care testing, and then shifted to providing testing capability as a main focus on our efforts. And certainly after the testing ramped up, then the therapeutics became available. So getting that clinical education to our providers and information out to our service units about the remdesivir, which is an antiviral, the monoclonal antibodies, getting those out to focus on all three, prevent, detect, and treat. We rapidly also became aware of the challenges with substance use disorder, behavioral health issues that might be going unaddressed, and as well as the effects of that unresolved grief. And so focusing on recovery became important as well. So we added that as an additional part of our response. And then, of course, with the availability of the vaccine, we've come full circle to the prevention, again, with a new means of preventing the virus. And again, a lesson learned here is the importance of engaging with Native speakers, with tribal elders, with local community leaders, and tailoring messaging in partnership with tribes and local communities. Thank you.
Thank you, Dr. Totes. Our second question is for Dr. Christensen. Dr. Christensen, as a physician leader, what can you say to people and tell them to do about staying safe to help our medical professionals during this time?
Thank you, Dr. Grimm, for that question. The most important things we ask of everybody are to continue adherence to our public health measures, which we cannot say enough times. Watch your distance, wash your hands. If you touch any surfaces or even touch your mask, wash your hands or use the sanitizer. And certainly very, very important is to wear your mask. And I do want to emphasize today that the CDC has come out with new guidance concerning masks, and they are asking everyone over 2 years of age to wear a mask and to wear 2 masks. We're using a surgical or the thinner mask underneath, and then placing a cloth mask over the top to create a better seal against the face. They feel this will help decrease exposure in public places or where you are. So they are advising us to get now 2 masks. So I pass that on to each and every one of you today. I also want to ask people to watch your COVID fatigue. We have been going at this for 12 months, and I know everyone is tired of staying home, wearing masks, and not being able to enjoy any social activities. But we have to be very, very careful to not rebound after these 2 waves that we've suffered, at least in our Navajo area, 2 waves, as surrounding areas open up. Please take precautions. Do not go to large gatherings or events. Wear your mask everywhere, except for when you're home with your own family. And then if one of your family members is ill, we do even suggest wearing it at home. Make sure that if you do go out to eat as restaurants begin to open, that it is a properly socially distanced restaurant, or eat outside where there is more movement of air. When you work off of the reservation land or go to school, when you return, you have to be very careful. Many of our cases during the second wave were for people who work hard or go to school and wanted to come home. And when they came home, they brought COVID with them because they had been exposed where they were working or going to school. With the new variants that have been identified across the country, this has become even more significant as we continue to try to vaccinate the vast majority of our population. You cannot stop any of these safety measures, because the better you take care of yourself, you protect your family, your friends, and your community, and you help us at the healthcare facilities, because that decrease in cases allows us to care for non-COVID patients and to reopen services for you for clinic follow-up, for management of your disease processes and your wellness. So my last advice to everyone is please strongly consider getting vaccinated. We do depend on you for the health of our communities, and the more of us that get vaccinated, the more protection we have. And despite the variant, it is still the most tangible tool we have to defeat COVID. So please wear your masks, watch your distance, wash your hands, and please get vaccinated. Thank you.
Thank you, Dr. Christensen. I also, as a health professional, would encourage everyone, please do that to protect everyone around you. Our third question is for Ms. Davis. As a tribal leader, Ms. Davis, not only in your tribe, but as one who sits on a tri-state regional health board, have you found that vaccine confidence among tribal communities is an issue as you're trying to implement your vaccine plans?
I think for the Great Lakes area, the tribes, because they are in alignment in so many different ways and processes and how they work towards the pandemic and testing and educating, and then the planning and distribution. There is vaccine hesitancy, but also the goal for the tribes is really to educate. Many of our tribes are smaller communities, and maybe the outreach and the ability to offer that education and information might be a little bit easier regionally, short distancing between tribes, or just the messaging, the kind of communications our tribes put out. I believe that I did hear just recently from a tribe who mentioned that their tribes were so grateful that they follow the priority, and they were looking at their elderly, and they had issues about people who cared for them weren't in the same priority. But, as this process has evolved, tribes as sovereign nations make determinations on the best interest of their tribes. And many times the communities in which they live in, reservation boundaries might exist, but they live in communities, and they have those close social and economic ties. And so the ability for tribes to look at this in a way that protects their elders, protects their citizens who are compromised with, severe health conditions. They make decisions on how best to protect their community, and that might include, those non-Bens that are able to access services as a employee of a Gun Lake Casino or as a nurse of a clinic. So we have found that, but yet we've been very encouraged. I was on a call at noon today, in the Bemidji area director, Daniel Fry, had mentioned a CDC website, a link that he offered up, and there was someone from CDC that said they could offer technical support to communities to talk about vaccine hesitancy and techniques or information that they will certainly be willing to assist with turning that around. So I'm very hopeful about that. I thought that was a great message.
Thank you, Ms. Davis. I want to thank all of our speakers for those insightful answers to these first questions. And with our remaining time, what we're going to do is try to take a few questions from the audience. And we've been monitoring the questions that have come in, and our behind the scenes teams have placed them in the same format. So I'll ask for the first question, please. What is the #1 need to help combat the pandemic in Native communities currently? More federal money, more vaccine doses, or what? And that is a question that I think all three of our speakers might want to answer. And I'm gonna, so they don't speak over each other, which happens all the time on Zoom these days and webinars, I'm gonna give them each an opportunity, and I'm gonna start with our tribal leader out of respect. Ms. Davis, you don't need to answer this, but if you'd like to, I'll give you the opportunity. Then I'll do the same to Dr. Christensen and Admiral Tote.
Well, certainly I do want to answer this, and I think that it's something that the Indian Health Service as a federal agency is in need of as well, and that is increasing the funding overall to the Indian Health Service. We're chronically and historically underfunded, and my region out of the 12 Indian Health Service regions is not alone in that. Looking at initiatives to bring to the front public health initiatives that create healthier paths for American Indians versus treating them on the back end when they're sick and they're going into the clinic or the hospital. Investing funding in at the front end of this. And so I think that there's so many ways that we could do this. Accruing additional funding through appropriations of the coronavirus pandemic. Many of these packages that came out had so many restrictions that are related to the appropriation languages from whatever agency they're going to go to, if it's CDC, SAMHSA, NIH, HRSA. It's very hard sometimes to navigate them. Tribes have some real difficulty with navigating funding and restrictions in relation to how they come out of Congress. So I think those things are really high level issues that need administrative insight, information, and just some good push. And I'm hoping this new administration is able to look at the Indian Health Service and commit to working with us and improving the lives across the nation.
Thank you, Ms. Davis. Dr. Christensen, I'll offer you an opportunity at this question if you'd like as well.
Thank you, Dr. Grimm. I believe there's two things that are very, very important. The first would be, yes, we'd like to continue our supply of vaccines. We're very grateful for what we've received. We've been very efficient and timely in administering them, and our goal is to vaccinate the majority, if not all, of our Navajo people in our effort to build immunity throughout the Navajo Nation. The second thing I do want to speak about is post-COVID care. As I mentioned before, I believe this is something we have to focus on now because we're going to need a lot of resources, and it will take some time to develop those resources. And as you know, many of our tribal facilities and our healthcare facilities for IHS are located in what I call extreme rurality. They're very, very far out. So the things that they need are different than people will need in a suburban or urban area. So looking at the post-COVID care, how do we get specialists to these very rural areas? Well, we are going to continuously improve our telehealth capabilities, which headquarters has been working on very diligently. We want to make sure we assess them and get them any equipment or supportive services that they need. And we want to work towards developing some of the programs such as Hospital at Home from CMS, where we actually can provide more care out into the communities to reach those that can't or are not able to get to our facilities. So I want to advocate very strongly for focusing on bringing these resources into all of these tribal communities for neurocognitive rehabilitation, for specialties of pulmonology, neurology, and cardiology for the sequelae, the very serious sequelae of COVID. And we can't forget these people who have survived COVID once the pandemic's over, because their symptoms and sequelae will go on, some for well over a year and some permanently. So those are my top priorities right now concerning the pandemic. Thank you.
Thank you, Dr. Christensen. Admiral Tote.
Thank you, Dr. Grimm. Certainly, I agree with both of the previous answers, Ms. Davis and Dr. Christensen. I will add to that American Indians and Alaska Natives have been disproportionately affected during this pandemic, and we really need to address those root causes. It's important that we address issues that affect lower health status, lower life expectancy, and the disproportionate disease burden that exists. And I strongly believe that this is related to the disproportionate poverty and that there's broad quality of life issues rooted in economic adversity and poor social conditions. So I think that that combating these issues that are traditionally called social or economic determinants of health is paramount. Of course, I do hear from tribal leaders that we need more resources, more vaccine, and I agree with the statements about dealing with proactively following patients for long hauler symptoms and addressing them as well. But I really think that the broader issues affecting health equity need to be addressed.
Those were all great responses, very comprehensive. Question number 2, please. Does the strategy of the 3 Ws have any conflicts or challenges with cultural practices of different nations? And again, I'll start with Ms. Davis, and if you all prefer not to answer this one, just please tell me and I'll move on. So Ms. Davis?
Dr. Grimm, could you repeat that, please?
Does the strategy of the 3 Ws, wearing your mask, washing your hands, and watching your distance, have any conflicts or challenges with cultural practices of different tribal nations?
Well, I think I'd want to say that there might be personal challenges with that as an individual, but tribal nations overall do look at the best interests of their citizens. You know, we've had to implement some practices in relationship to if one of our tribal citizens passed on, you know, and just the ceremonial processes have been a huge challenge in that. So along those lines, you know, that's in the best interests of our citizens. And so we've encouraged that. Now, you can't make people fall in alignment with what you're teaching and trying to educate them on. They're going to make those choices, but we've tried certainly very hard to encourage that. We've had citizens who have passed away in my community this winter whose family did traditional fires. They did maintain social distancing. They did use their masks. We couldn't have feasts together like we normally do. So, you know, they've been able to work out what they need to do to honor that person that's walked on. Thank you.
Thank you, Ms. Davis. Dr. Christensen, would you like to respond to this one?
Yes, thank you, Dr. Grimm. It has been very challenging, the whole entire pandemic on the Navajo Nation, because there are a lot of ceremonies that are very typical, a lot of celebrations, a lot of events that are very special to our traditions in Navajo. So it has been challenging to encourage people to abstain from their participation. It also, even on the family level, like most tribal communities, families are very close. People are very close in their communities. And to not gather and to not have that socialization has been extremely isolating for many of our people. So, but I will say I'm very proud and very thankful to the Navajo people for wearing their masks and doing the 3 Ws, because when I walk and I'm traveling out throughout the area, I see masks on everybody. Everybody is complying. They're doing their very best to protect themselves and others. So they've really stepped up and done a fantastic job, but it is very challenging to us to not be able to do our traditional ceremonies and gatherings. So a lot of credit to the people for that. And hopefully there'll be a time soon when this can resume. Thank you.
Admiral Tote, your thoughts on this question?
Thank you, Dr. Grimm. Completely agree that, you know, the 3 Ws of wearing a mask, washing your hands or using sanitizer, and watching your distance or waiting 6 feet apart, those are uniquely embraced by different communities in different ways. For urban Indians, waiting 6 feet apart may make more sense because they're more likely to encounter lines more often in urban environments, whereas all of us have different cultural approaches to shaking hands or embracing or gathering for festivals and ceremony. And so it has been, I think, a challenge to get the messages to the why and how it helps, and have that delivered really by respected tribal leaders, tribal elders in the community, so that it can best be accepted. I do want to share that in the Q&A, there's an opportunity also for the answered questions, which have typed answers, and I did provide in there some links which have some materials developed for tribal use, ihs.gov/coronavirus/resources, and then CDC has resources for tribes on their website as well. It's a longer link, but that's at cdc.gov/coronavirus, and I have the full link in that answered question section. Thank you.
Thank you, Admiral Tote. And as he pointed out, We have a panel of experts behind the scenes that are trying to respond to these questions that come up, because as I see those numbers on the screen below me, we won't be able to get them all here to be answered as part of the webinar. So those of you that have come up with questions, please keep your eye down there as well. The next question, please. How did the CARES Act funding factor into the public health response? Ms. Davis, would you like to start us out again?
Sure. The CARES Act was a magnificent bill, passed through Congress to provide resources to the American Indian population who were facing, very, very high rates of death and disease. They were spread across multiple places to implement care for testing, for supplies, PPE, to support infrastructure within tribal health centers, and expanding telehealth, improving data reporting. There were so many different places that you could utilize the funding to support those essential staff workers. For many tribes in the nation, they utilize federal funds, they utilize grants that they apply for. They might have economic development, which might be gaming, that they'll have a revenue stream coming. But the majority of the tribes in the nation, maybe at one time or another, I know certainly for the Great Lakes area, the majority of the tribes closed their gaming sites down, which, eliminated that revenue stream. So there was, there were funds that were expended that that were going to need some way to shore back up, and the CARES Act allowed the tribes to support ongoing benefits, salary for those who needed, who we were looking at as essential. As I mentioned before, there were some issues with CARES Act and how restrictive some of the language was, but the tribes mainly worked through that. Thank you.
Thank you, Ms. Davis. Dr. Christensen.
Yes, so the CARE Act funding has been very beneficial to us out in Navajo. We've been able to provide a lot of services and use it for treating people for COVID and for testing and et cetera. So one of the main areas, as I mentioned before, up to 30% of our homes don't have running water across Navajo. And the funding that has come down through allowed us to create a workforce with our environmental engineering workforce out of IHS, in combination with the Navajo Nation and multiple philanthropic and state-based universities, to attack this problem. So we have been able to begin opening water access points, distributing water tanks and disinfectant tablets. We've been evaluating all of the areas to bring more services in. The local utility, NTUA, has been able to hook up quite a few homes to electricity that didn't have access before. So I think it's been applied excellent across Navajo. We had a lot of funding for testing, and which supports our contact tracing efforts, and a lot of the behind the scenes work that our exceptional staff is doing. So we're very grateful for that. It allows us to keep our isolation sites and provide ACS, or alternate care site care, and allows us to provide extra staffing for testing throughout Navajo. So it has been a great factor for us, and we are very appreciative of the funds. Thank you.
Thank you, Dr. Christensen. Dr. Toad, as a health leader of the agency where many of these funds flowed through, what is your viewpoint on this question?
Thank you, Dr. Rimm. The Indian Health Service did receive more than $1 billion through the coronavirus response through the CARES Act. I want to circle back to the whole of government response as well, because there were CARES Act funds that went through HUD for Native American housing issues. There were CARES Act funding that went through SAMHSA for grants for substance abuse and mental health services. So really, the CARES Act funding was just enormous in terms of the all of government response, and that's just a few of the other agencies or departments that receive funding. Through IHS, as Dr. Christensen mentioned, there was a lot of good done in the local communities. The first thing that we did was to conduct rapid tribal consultation and urban confer sessions to seek input from our partners on distribution of those resources. And then the distribution really very much did support the response at the local level, with the vast majority of those funds going out to tribal health programs and to urban Indian organizations. It did also support funding of the distribution of personal protective equipment, masks, gowns, respirators, and as well as supported the activities to distribute the therapeutics, and really has helped us also in terms of our response coordination as well. But the vast majority of those funds went directly to tribes and urban Indian organizations upon consultation and urban confer.
Thank you again to all three of our panelists. We have another question. I'm a contact tracer as well as a nutrition and maternal health advocate. How can I support Indigenous communities in need? And again, I'll go to Ms. Davis, if you'd like to respond first.
Well, thank you. Contact tracing is a really vital tool to use within Indian communities, and offering services to train people up to volunteer, reach out to the tribes in whatever community you live in, or if you're in an urban area, maybe a urban health center, you could volunteer, or just put the requests out there that you're willing to do this. For regions like mine, the Great Lakes area, the CDC Foundation offered people who could help train us up with contact tracing, and it was very instrumental in many of the tribes in the Great Lakes area being able to educate their communities and their staff on this as well. Thank you so much.
Thank you, Ms. Davis. Dr. Christensen.
I echo what Ms. Davis said. I can put in the chat our email for our volunteer manager, who has brought in over 500 people to help us during the pandemic and can steer you to the right place. And we're always happy for people to volunteer to help, and we appreciate your support and concern. Thank you.
Sounds like you may have just found a job if you don't have one right now, for the person who put that question in. Admiral Tote, your response, please.
Thank you, Dr. Grimm. I don't have a whole lot to add. I think that those responses are right on the money there. We don't, this is a new virus. We've only had just over a year's experience with it, and we don't fully understand what the effects on moms and unborn children will be, if any. But we know that that we have to very carefully make sure that we monitor moms and unborn babies and children in order to identify whether or not there are any effects and to mitigate those. So that support on the maternal health side, I think, is always welcome. And then in terms of nutrition, we know that underlying chronic disease puts you at higher risk for COVID-19. So addressing those underlying conditions continues to be important. And then with respect to the contact tracing, that's as I think that Dr. Christensen covered that well, so I won't add any more to that one.
Thank you, panelists. Next question, please. It's startling to hear the number of Navajo that did not have access to running water and electricity. And certainly this makes hand washing and telehealth appointments more challenging. What is the federal response to get more homes connected to water and electricity? And Ms. Davis, I'll start with you again, but that may be a more federal response if you care not to tackle that one.
Yeah, I'd really like to defer to the IHS and to the Navajo Nation.
I will start with Dr. Christensen then.
Okay, thank you for the question. And yes, I do concur that when you look at amenities across the United States, to see that there are places in the United States that don't have basic amenities such as running water and electricity is concerning. However, we have begun mitigating this problem in Navajo, again, fortunately for funds that were distributed and in close partnership with Navajo Nation. Our Office of Engineering and Environmental Health at IHS have worked very closely to organize projects that will continue throughout the pandemic and much after that. As we try to work towards health equity, it's very important that we address our infrastructure issues as quickly and efficiently as possible. So we are already establishing increased water access points, delivering more storage tanks to people, helping them learn about disinfectant tablets so that they drink safe water. We're also assessing other areas across the reservation to continue and expand this project. In the terms of electricity, we've been very fortunate to work with the utilities companies, and they have done some excellent pushes to get electricity to certain areas, and they've hooked up quite a few homes. Of course, we won't be satisfied till everyone is hooked up and everyone has the ability to have electricity and water. This has been very important in the pandemic, and it is one of the reasons I feel we were so deeply impacted, because it's hard to wash your hands frequently when you don't have access to running water. It's very difficult in small multi-generational homes to distance when you have no room to distance. And certainly when you even look at medical treatment, those that may need oxygen where they need to plug in their regulators into an outlet, they don't have any electricity. So we in Navajo deal with these disparities every day. Our staff is excellent at dealing with this under normal circumstances, and certainly it did raise the challenge during the pandemic. So we will continue to mitigate and work with the Navajo Nation to strengthen services across the area for all of the people in Navajo Nation. So thank you for that question.
Thank you, Dr. Christensen. Admiral Tote, your response, please.
Thank you. I'm fishing around for these buttons again. Apologize for the delay. So the Indian Health Service has been working closely through the Office of Environmental Health and Engineering to work together in partnership with Navajo Nation and the Navajo Area IHS to ensure that there is expansion of access to safe water on Navajo Nation. In fact, there was a project that was using $5.2 million from IHS appropriated CARES Act funding, which was partnered on to help increase the water access for the Navajo Nation. We respect that it's a very complicated issue with the broad distances and engineering challenges they have. But they are doing a great job and increasing access to water. So a lot of kudos and congratulations. More to be done there.
Thank you. I think we have time maybe for one more question for our panelists. And a tribal elder from Wisconsin would like to know how tribes can prevent their young people from going off the reservation to areas where COVID-19 cases are higher. Some tribes don't have curfews. Ms. Davis.
Yeah, I did send a message out to that person as well. It's really unfortunate, but I think I'm just going to make a general assumption. Younger people just are high risk takers. We've found that in American Indian populations to be true. I think the general population, young people, do not believe that they're not afraid. And they take that attitude with them in many of the things they do. And they believe that they can manage whatever's going to come their way. I guess it's part of the, them wanting independence, being an adult, making their own decisions and choices. We have this discussion all the time about, talking with young people and encouraging them to think about the people that they live with, live around, who they're connecting with. And as we've mentioned, the COVID fatigue that we've all experienced over the last 11 months, the need and want to socialize, to be in the mix of life and activity has had a really deep and dark impact on us all. And in the communities of, like the American Indian population, where we've seen, increases in depression, mental health issues, substance abuse, suicide. These younger people are just looking at, I'm just going to do it. But encouraging them to pay attention to, who they love and their families, and thinking about them, and many of the chronic and serious conditions that they might be living with. Maybe they have an auntie or a grandma who is on dialysis, and the devastating impact of somebody who could contract the COVID-19 virus, but not have symptoms, but could pass it on is devastating. And so offering up those kinds of education, I think, is really vital to our young people, and just, supporting them and trying to encourage them to sit tight. Thank you.
Great response, Ms. Davis. Dr. Christensen, same question.
Yes, and Ms. Davis, thank you for those great points, because we saw the same trend in Navajo. Our initial demographic for the most cases was in the 50-year-old and above range, and it changed over time to the 24 to 35-year-olds. So we were very cognizant that it was our young people that were out and about, and we had to change our public messaging. So you have to be very fluid with that messaging, and you have to use the media that young people use, because they weren't going to be on the same radio station as their grandmas and grandpas, but they would be more on Facebook and some of the other social, Snapchat, Instagram, etc. So we changed a lot of our public messaging to focus on that group, because we also believe they were probably a large percentage of the asymptomatic population that was unknowingly exposing others. So we do the same things. We were very fortunate. Our Navajo Nation President Nez has been very, very active, and he's worked very hard with the public messaging and the public health orders. And we still have curfews, and we still have shelter at home recommendations, although we do know not everybody complies. I think it has helped a great deal, and it's supported our recovery. So we will constantly focus on those population age groups where we feel the message needs to be delivered. We try to send out messages. If you do go out, this is the safe way. If you do have to go off the reservation, and we encourage them to wear their masks upon coming back so that they don't inadvertently expose someone. So it is a challenge because they're young and healthy, but we do want them to stay well, and we do not want them to expose any of their family members. So thank you.
And Admiral Todt, I'm going to give you a pass on this last response, although I know you would have had a good one. You've had great ones for every question, but we are running out of time for our webinar. So I'm going to wrap things up now. This concludes our program today, but before we close, I'd like to thank Dr. Todt, Dr. Christensen, and Ms. Davis for the valuable information they've provided about preventing, detecting, treating, and recovering from COVID-19 in Indian country. I'd also like to express my appreciation to all of you for serving our American Indian and Alaska Native communities, especially during this pandemic. And for all of you who joined us today, thank you for finding time and visiting today's webinar. I hope you've learned something valuable today about the COVID-19 response efforts in tribal communities across the country. We've included links on the final slide if you'd like to learn more about the National Museum of the American Indian and the Indian Health Service. Thanks again, and everyone, please have a great afternoon.
Thank you.